All right. I'd like for us to go ahead and get started. And we are ready for our next presenter. We're very excited for this day. Uh, Here at 9:30, we will be hearing from Derek Humphres, who is going to be addressing us on his topic, which is development and implementation of a pediatric anesthesia workstation setup, or PAWS, P-A-W-S, PAWS tool. And Derek, if you want to unmute yourself, and you should be able to uh, share your screen by going to the bottom middle green button that says share screen. Yep, there you go.
Okay. Morning, everybody. I'm Derek Humphres, and like Dr. Gebhardt said, this presentation is the development and implementation of a pediatric anesthesia workstation setup or PAWS tool. Just the topics that we're going to discuss in this presentation are here. So the problem, anesthetic complications and mortality are significantly higher among pediatric patients than they are adults. And inconsistency during preparation contributes to increased frequency of missed components critical to anesthetic delivery. The omission of critical items such as medications or equipment during delivery of anesthesia can compromise otherwise high quality anesthesia care. The facility which we implemented this project at did not utilize a checklist during preparation of the pediatric anesthesia workstation prior to this project. The purpose was to develop a cognitive aid to be utilized by all anesthesia professionals during workstation setup prior to pediatric anesthesia cases. We determined the goals to be to decrease variation among providers, eliminate omissions of critical components of pediatric anesthesia, and improve patient safety. I began this project by conducting a thorough literature review, utilizing the Cochrane Library, the Cumulative Index to Nursing and Allied Health Literature, or CINAHL, and ProQuest Nursing and Allied Health Source, using these search terms here. Articles were limited to full text articles, those in the English language and published within the prior 10 years. The initial search resulted 74 articles. Articles were then identified as relevant based on checklist use among pediatric patients undergoing anesthesia, comparison of adult and pediatric anesthesia, and outcomes associated with cognitive aid use in healthcare. Articles identified as relevant were then assigned a level of evidence based on the levels of evidence identified by Mylink and Feinout-Overholt. Level 1 included 2 systematic reviews, 1 clinical practice guideline. Level 2 included 3 randomized control trials, and level 3 included a control trial without randomization. The remaining 8 articles were determined to be of lower levels of evidence, including synthesis of qualitative studies, descriptive studies, and expert opinions, which were levels 5, 6, and 7, respectively. The literature review revealed 3 broad topics, including differences between pediatric and adult patients, the need for specialized equipment, medications and techniques, and finally, current use of checklists in anesthesia in healthcare. The chart here on the left identifies many of the anatomical differences between pediatric patients and adults. Some of the most noticeable differences include a large head size and prominent occiput, which leads to a flexed neck position, misalignment of the oral, laryngeal, and pharyngeal axes, and ultimately an increased risk of airway obstruction. The large tongue, small jawbone, and enlarged tonsils and adenoids may reduce upper airway space, causing greater difficulty during direct laryngoscopy and intubation. And then finally, the omega-shaped epiglottis and differences in the narrowest portion of the airway may require the anesthesia professional to utilize special equipment such as a MAC versus a Miller blade or a smaller endotracheal tube. Aside from physical differences, physiological differences also exist, such as higher resting metabolic rate, increased oxygen consumption, and a greater carbon dioxide production. These differences contribute to pediatric patients' significantly quicker onset and emergence from anesthesia, but they're also likely factors responsible for the rapid desaturation and deterioration during apnea. The literature also identified the most frequent causes of complications during pediatric anesthesia to be inadequate preoperative evaluation and insufficient preoperative planning. Finally, my literature review, it was noted that facility-specific guidelines, algorithms, and educational programs, which focus on differences of anesthetic delivery for pediatric populations, can reduce costs and incidence of complications related to pediatric anesthesia administration and improve overall patient safety. The anatomical and physiological differences which exist among adult and pediatric populations also necessitates special consideration to be paid to equipment and medications. For example, endotracheal tubes, due to the anatomic variability and potential for adverse outcomes associated with incorrectly sized endotracheal tubes, selecting an appropriately sized tube is crucial. One which is too small may result in the inability to effectively occlude the airway, resulting in ineffective ventilatory control, or one which is too large may increase pressure placed on the trachea mucosa, excuse me, resulting in tracheal edema and an increased risk of post-op extubation airway occlusion. Also, laryngoscope blades, the anatomical differences of the epiglottis of neonates particularly, and children up to 3 years may necessitate the use of a straight or Miller blade versus a MAC or curved blade that can be used and is often used among larger pediatric patients and adults. Finally, many of the medications commonly utilized in pediatric anesthesia are calculated based on the weight of the patient. So minor errors in dosing can have detrimental outcomes among the smallest patients. Ensuring correct weight-based calculations are particularly important as pediatric patients exhibit increased cardiac output, increased minute ventilation, and decreased muscle and fat content. All of these can affect the pharmacological response to anesthetic medications. The literature does recommend anesthesia providers calculate weight-based medication dosages prior to setting up the workstation. This is especially important in emergency medications such as succinylcholine, atropine, or lidocaine, as these may require prompt administration in the event of rapid patient deterioration. Cognitive aids and checklists have been used in other industries such as the aviation industry for more than 80 years because they improve performance and eliminate oversights, because they allow the user to be reminded of items required or steps to be taken, decreasing the reliance on memory alone. More recently, the World Health Organization has focused on the use of cognitive aids in the healthcare setting, particularly the surgical safety checklist. Use of this checklist has resulted in significantly decreased surgery-related mortality and morbidity. In a 2009 study examining more than 7,500 patients undergoing surgery, the surgical safety checklist improved compliance more than 20% with all measured safety indicators, decreased perioperative death rate by more than 40%, and the overall complication rate fell by more than 35%. Similarly, in a study of more than 9,000 procedures, Devv and colleagues found that the surgical safety checklist decreased post-op complications by 10% and reduced patient mortality by 50%. Evidence in support of the surgical safety checklist is so strong that the use of it has been deemed a global standard of care by both the World Health Organization and the World Federation of Societies of Anesthesiologists, international standards for safe practice of anesthesia. Arriaga and colleagues found adherence to advanced cardiac life support, or ACLS, practice guidelines improved by nearly 75% when surgical checklists were utilized during high fidelity simulated emergency scenarios. When the checklist was used, the rates of failure to correct this simulated patient deterioration were also significantly lower. It was also noted that providers using checklists feel more prepared to intervene during a crisis. Together, these findings suggest that situations which rely on timely, critical action by the provider, checklists possess the ability to positively impact the clinical practice and patient outcomes. Despite extensive literature demonstrating the benefits of checklist use in organizations such as the World Health Organization, recommending the performance of a pre-anesthesia safety check, an information deficit does still exist. Current literature demonstrates limited information regarding checklist use during preparation of the anesthesia workstation, specific aspects necessary during that preoperative check, and a significant lack of a checklist dedicated solely to the preparation of anesthesia workstation for pediatric patients specifically. Due to the lack of a previously published pre-op checklist dedicated to the pediatric patients and pediatric anesthesia specifically, I was required to develop a completely new, unique checklist devoted to that population. The theoretical framework chosen to guide this project was Benner's novice to expert theory, as it describes concepts related to skill attainment among nurses. Benner suggests one cannot effectively become an expert without situational experience, and suggests nursing skills are acquired and developed as the learner passes through 5 proficiency levels, including novice, advanced beginner, competent, proficient, and expert. This theory was chosen with the intent that the resulting checklist could be utilized by anesthesia professionals across different levels of proficiency, from novice to proficient. In addition to a theoretical framework, successful development and implementation of the proposed change required utilization of a change model to aid in determining practicality, relevance, significance, and efficacy of the evidence to support the proposed change. I used the model for improvement as the organizational framework in designing the PAWS tool, as it's been widely accepted by the healthcare community and utilized to evaluate and disseminate research into clinical practice across the US and multiple different countries. The model for improvement has been selected due to its use of the Plan, Do, Study, Act cycle, or the PDSA cycle, which utilizes a continuous feedback loop, allowing quick testing of a change on a limited basis, analysis of the effectiveness, and refining the change prior to a broad scale implementation. The PDSA cycle follows a cyclical progression, which allows for continued development and evaluation to occur, thus constantly improving processes. The model for improvement addresses the fundamental questions of what is to be accomplished, what change can be made to achieve the goal, and how will the change be measured to determine success. The setting for this project was a private 300-bed not-for-profit Midwestern Hospital, a designated level 2 trauma center, and the principal clinical site affiliate for nurse anesthesia program. The sample included registered nurse anesthesia interns of the 2020 cohort entering their early pediatric clinical rotation during the fall of 2019. The first step in the PDSA cycle was to identify a process which can be improved upon. I began by organizing a dedicated multidisciplinary team, including Dr. Dana Flatley, Dr. Joe Carter, and Lindsay Beery. Together, we established the goals of improved consistency among novice anesthesia providers while delivering anesthesia to pediatric patients, decrease provider variation, and eliminate omissions of critical components of the anesthesia workstation. Once our goals had been established, a thorough literature review was conducted. In addition to the literature review, I worked with the multidisciplinary team to examine steps taken by anesthesia providers in preparation for pediatric anesthesia, including required medications, equipment, and the anesthesia machine setup process. This information and information from the literature was used to create the first iteration of the Pediatric Anesthesia Workstation setup tool, or the PAWS tool, which is pictured here. The tool is designed to assist new anesthesia providers throughout the setup of their workstation, including the anesthesia machine, suction, monitors, airway, intravenous access, anesthesia medications, and any special equipment which may be required. Anesthesia providers working within the implementing facility were asked to review this tool and provide feedback. Based on the feedback received from these anesthesia providers, the PAWS tool was reworked using the recommendations to create a usable PAWS tool, which is seen here. On the left is the front page, on the right is the back page of the tool. The do phase consisted of conducting a pilot study. First, anesthesia interns were educated on the PAWS tool during Clinical Practicum 2 course. Interns were then asked to utilize the PAWS tool between August 26th and December 21st, 2019. To ensure adequate access to the PAWS tool, copies were distributed via email to each anesthesia intern. Copies were located within the anesthesia office, and a digital copy was uploaded into Moodle, the web-based platform used to provide access to essential clinical documents. Following the pilot study, interns completed the PAWS tool anesthesia provider feedback form between December 30th, 2019 and January 9th, 2020. To ensure anonymity, interns were asked to deposit completed feedback forms into an envelope located within the anesthesia office, completing the second phase of the project. The study phase of the PDSA cycle was key in determining the impact the newly implemented change has had on the organization. Student evaluations from the 2020 cohort were compared to those of the 2019 cohort to identify if utilization of the PAWS tool had been effective in reducing omissions of critical components of the pediatric anesthesia workstation. Additionally, the provider feedback forms were evaluated, observing for identifiable trends in users' perceptions of the tool, its usability, and any recommendations which may be used to improve the PAWS tool in the future. Based on the data elicited during the study phase, the final phase of the PDSA cycle provides the researcher the opportunity to adapt or adopt or abandon adapt being make modifications for future PDSA cycles. Adopt would be to implement the change on a broader scale, and abandon would be to abandon the process or proposed change entirely. Based on the data obtained during the study phase, the decision was made to adopt the PAWS tool. The PAWS tool was then submitted to the Director of Anesthesia to be implemented into clinical orientation for future anesthesia intern cohorts. Upon completion of Clinical Practicum 2, I distributed 12 PAWS tools, anesthesia provider feedback forms to the 2020 cohort of registered nurse anesthesia interns. The interns were asked to anonymously complete and return the feedback form to a designated folder within the anesthesia office. Of the 12 forms distributed, all 12 were completed and returned anonymously. The results of the anesthesia provider feedback forms have been compiled and are presented in this table. In this questionnaire, questions were asked like, such as, did you use it, the PAWS tool during your workstation setup? Did you find the tool to be helpful when setting up the workstation? Would you use the tool again when setting up for pediatric cases? And then asked for anything that needed to be added or any additional comments that could be made. Of particular note, all the respondents indicated the PAWS tool was helpful in preparing for pediatric anesthesia and that they would use the tool again when preparing the workstation for pediatric patients. The most common recommendation made regarding the tool was that medication concentrations required continuous updating based on facility availability. Due to my previous standing as a member of the 2020 cohort, Dr. Flatley reviewed the clinical evaluations for the 2020 cohort to ensure anonymity, while I reviewed those of the 2019 cohort. We compared student clinical evaluation forms for Clinical Practicum 2 between the two cohorts, observing for any indication of an incomplete workstation. For purposes of this project, an incomplete workstation is defined as an omission of any item contained within the PAWS tool. On comparison of the data elicited from student clinical evaluation forms completed during Clinical Practicum 2 for the two cohorts, a significant decrease in incidence of workstation omissions from 4 to 1 following implementation of the PAWS tool was noted. It has been concluded that patient safety has been positively affected. And this information supports continued utilization of the PAWS tool by future cohorts of the nurse anesthesia program. Based on the overwhelming positive feedback and the decrease in incidence of workstation omissions from 4 to 1, it has been concluded that patient safety has been positively affected, and this information supports continued utilization by future cohorts of the nurse anesthesia program. A couple limitations and barriers that I experienced during this project. Obviously, an absence of a model checklist was a limitation. I was forced to create a completely new checklist rather than adapting an existing checklist, which had previously demonstrated success in anesthesia practice. Also, this tool is hospital and program specific, being that it was designed specifically to meet the needs of the anesthesia practice at the implementing facility and associated anesthesia program. Due to the specificity of the PAWS tool, the checklist may require modification prior to implementation at other institutions, and finally limited sample size. I did obtain 12 participants from the registered nurse anesthesia intern cohort of 2020. However, based on the narrow timeline available for project completion and limited enrollment into the nurse anesthesia program, I was limited to participation of only one cohort. And then finally, sustainability. To ensure continued integration of the PAWS tool into the practice of future anesthesia intern cohorts, the tool needs to be easily accessible and readily available. Working with the interdisciplinary team, we decided to interject the PAWS tool in 3 different locations for future cohorts. First, it'll be introduced in the Ready for the Day lecture, which is a lecture interns will be provided education regarding appropriate use of the PAWS tool and benefits of integrating the PAWS tool into their practice. This is a lecture that occurs for all anesthesia interns prior to beginning clinical rotations. The PAWS tool will then again be revisited during Advanced Principles of Anesthesia 2, specifically lectures regarding pediatrics, where interns are provided in-depth education related to delivery of pediatric anesthesia. And finally, hard copies will be printed and located within the anesthesia office to provide interns with easy access to this tool on a day-to-day basis. A couple recommendations that I've made based on this project. First being to continually revise medication concentrations. Due to factors beyond the control of myself or the research team, such as changes in manufacturers or supply chains, medication concentrations should be continually updated based on availability at the implementing institution. Also, the addition of pediatric mask sizing or oxygen mask sizing. I definitely do support adding such a chart to the PAWS tool to guide users in selecting the appropriately sized pediatric oxygen mask. And then finally, several recommendations on the feedback forms requested the inclusion of additional patient calculation columns. However, due to the potential for unintended patient harm secondary to delivery of inappropriate medication doses, I do not recommend adding supplementary patient calculation columns on that second page. Instead, I recommend that the PAWS tool is a one-time use tool intended to be renewed specifically for each pediatric patient. These are my references and time for questions.
Very good, Derek. Thank you very much for your presentation. So from our guests in the audience, do you have questions for Derek? Don't forget you have to unmute yourself.
Great job, Derek. I use that every single time I have a PD case.
Thank you. Glad to hear that it's helpful.
Congratulations.
Thank you.
It's great. Great job.
Thank you. Thank you.
That's right. Congratulations.
Thank you.
Ta-da.
Good job, Derek. Sorry, I don't have a sign for you.
Disappointed.
A massive fail. Epic fail, I guess, right? As the kids would say.
I think that's what they say.
All right. We'll see you soon.
Thank you. Appreciate it.
I see from the comment section that me has commented, nice project. Very true.
Thank you. Appreciate that.
If we have no other questions, then we will end this session, and we will be back at, I believe, 10:15 for our next speaker. So time for another break. Thanks, Derek.
Thank you all. Have a good day.